My name is Peter Panagos. I'm a professor of emergency medicine and neurology at Washington University in St. Louis, Missouri. And it's my pleasure today, it's my sincere pleasure to be here with Anne Alexandrov, who is a professor of nursing and neurology at UT Memphis Health Science Medical Center. Um, Very exciting time. Yesterday at the opening session, main event, and had the honor of presenting your science, the ZODIAC trial. Must have been a career highlight to be in front of 3,000 or 4,000 of your close friends and family. I'm sure it went extremely well, and we were all very excited to hear about the ZODIAC trial. So for those of you who do not know, ZODIAC trial stands for zero head position in large vessel acute ischemic stroke, looking at zero head position versus 30 degrees, and we'll talk a little bit about that in a second. So Anne, can you tell a little bit about, for those who don't know much about head position, how did you arrive at this trial, and what is some of the things we need to know about the physiology of head position, and particularly in the setting of stroke?
Well, years back when I was doing my PhD, I had a big interest in this because we know that in the arterial territory where the stroke is occurring, that there's a vasomotor exhaustion of the arterial vasculature. And with that exhaustion, you have kind of a passive feeding of blood into that territory. And so it seemed to me that we needed to understand when intracranial pressure happens, because back in the late 90s, early 2000s, that was a big question that a lot of people had, that if you had any neurologic diagnosis, your head of the bed should be up 30 degrees to manage intracranial pressure. And so that was one of the first things that we looked at, and we found that no, these patients don't have intracranial pressure. In fact, their pulsatility index on TCD was absolutely normal. And so we kind of debunked that myth first. And then it seemed to me that if you put the head of the bed down, that you might actually see a difference in flow into that territory. The mechanism, which we've now pretty well confirmed, and others have as well with numerous small studies, shows that that gravitational force in that passive vasomotor exhausted bed really kind of takes over, and it does two things. One, even though you may see what looks like a complete occlusion on an arteriogram, what you actually see if you look at TCD at the occlusive site is that in about 80 to 85% of patients, there is blood getting through. It's just a suboptimal amount of blood, hence the stroke symptoms. So putting the head down actually increased the flow through that residual lumen by 20% from 30 degrees in a repeated measures design. And we published that back in 2005 in the journal Neurology. And then the other piece is that it likely helps to recruit collateral channels. And so combined those two things with the head down position, we noticed in a small sample of our patients, and others have seen as well, that they had some clinical improvement. We felt like we couldn't do any kind of definitive work until first we figured out what the standard of care was for large artery occlusive stroke, hence the thrombectomy trials through the later half of the first decade of the 2000s. And then after things had pretty much settled down, we thought, well, let's see if we can advantage these patients by putting them down at 0 degrees before the thrombectomy occurs.
And I think a lot of us in the stroke world are familiar with that a lot of your kind of sentinel work leading up to the ZODIAC trial, and certainly there's been a lot of work done in a pre-hospital emergency department in neuro ICU looking at perfusion and blood flow and collateralization. And certainly with advanced imaging, we know so much more than we do now than even probably when you conceived of this trial several years ago. So what was the funding source for the ZODIAC trial, and when did you begin recruitment?
So we were funded by the National Institutes of Health, specifically the National Institute of Nursing Research, with funding commencing in 2018. We actually were able to extend that funding to 6 years instead of 5 because of the COVID pandemic.
Right.
And that was probably the most challenging thing. We actually had several sites that were told you're not allowed to recruit during COVID, and for good understanding, of course. We had some sites that lost study personnel due to COVID that just didn't want to work anymore in an acute care setting and never came back to the trial. So that was very challenging too. So we were very flexible at leaving our site recruitment open throughout the duration of the trial so that we could maximize enrollment as best we could. But it was a challenging time.
It was, and we've heard a lot at this meeting of trials that really kind of ran through the pandemic and the challenges of maintaining energy and momentum and personnel in order to enroll and meet your enrollment thresholds during the pandemic. And there's some wonderful stories and some perseverance, and congratulations on you and your team for getting to the finish line.
In particular, my research coordinator, AJ, was amazing. She literally sat in the emergency department through the pandemic, masked and covered up and just, trying to keep herself safe. Fortunately, never got ill, but did an amazing job at our site in particular with enrollment.
Well, let's talk a little bit about the Zodiac trial. I think that's why we're here. So tell me a little bit about who was enrolled in this study, and what were the outcome measures that you were looking at?
We enrolled people that during the time of our recruitment, so 2018 through 2023, were considered standard of care thrombectomy patients. We started out saying that we'll limit it to people within the first 6 hours. And then, of course, Dawn and Diffuse came out, and we said, okay, if the imaging's favorable, you can go ahead and enroll that patient. We didn't enroll large cores. That information is really much more recent. And so we just, persevered with the methods that we had during that time. We ended up with a very diverse sample of all sorts of people, different ages and different races, but primarily anterior circulation stroke, with baseline aspect scores of 8 in both groups and baseline NIH stroke scale scores, which were taken at what we called time 0, which was immediately after all imaging was complete, while the patient was still flat after the imaging procedures. And that was 10 in each group as well for the NIH.
Okay, so big strokes.
Yeah. Big strokes.
All right. And as far as your outcomes, what did you study?
The primary endpoint was clinical stability and or clinical improvement on the NIH stroke scale prior to thrombectomy. Our assumption was that the thrombectomy itself would kind of level the playing field, so that to try and measure the endpoint, the primary endpoint after the thrombectomy might actually show no difference. We did, however, explore that endpoint as well, but the primary endpoint was all pre-thrombectomy. We had secondary endpoints as well that looked at 4 or more points worsening on the NIH during the head positioning procedure, as well as hospital-acquired pneumonias, of course, trying to do what anyone would consider a true aspiration pneumonia. You have to actually witness the aspiration. So we felt that hospital-acquired pneumonia was the fairest definition to use, and then all-cause death over the 3-month period.
Wonderful. And I guess we'll get to the results. As far as recruitment and enrollment, you always fear that phone call or email from the DSMB telling you that your study is halted. So this study actually was halted before your final enrollment goals, and that can be a good or bad thing. It was a good thing in this case.
Yeah, I really think it was the right decision on the part of the DSMB when we saw the study outcomes, which I guess we'll get to in a moment. Do you want me to share that now?
Well, let's do it.
I'd be happy to. The primary endpoint was highly statistically significant for clinical stability and or improvement in the 0-degree group compared to the 30-degree group. In fact, the number needed to harm to worsen 2 or more points on the NIH stroke scale was 1.88, which is quite remarkable. In fact, we asked the statisticians, please recheck that because that's pretty amazing. And they absolutely swear by their work. We then looked at number needed to harm for 4 or more points worsening, which was one of our safety outcomes. And that was 2.48. So really, for every 2 to 2.5 patients that you were to sit up, one patient was going to deteriorate significantly, which was really a compelling finding. So I do believe that the DSMB made the right decision.
Yeah. Those are wonderful results, and you don't see those type of numbers in most clinical trials. So congratulations.
Thank you.
And certainly that got the attention of the audience yesterday. So these outcomes, and I think you alluded to this during your platform presentation, were these outcomes extended out to the typical neurology outcome measure of 90 days?
We did explore the post-procedural, post-thrombectomy outcomes. And again, we didn't expect to see a difference because we figured that thrombectomy would be the big, maker of the difference. We were actually a bit shocked to see that at 24 hours, there was less neurologic disability in the group at 0 degrees, and that again at 7 days or discharge, whichever happened first, there was again less disability in the 0 degree group compared to the 30 degree head of bed group. So that was a huge surprise to us. Clearly, we want to look at more imaging data later in that group, but we do know that those two outcomes are not explained by the TICI at the end of the thrombectomy procedure, which was equivalent in each group. So hard to say exactly what could have been involved other than head positioning, but certainly compelling findings that may provoke additional research in the future or more secondary analyses of our imaging data, which we're hopeful that Brainstorm will do for us. The 90-day outcome, again, we didn't expect to see a difference there, and we didn't see a difference there. So it seems that people do catch up, although you can see a little bit of a shift visually on the modified Rankin scale. I think that, I would be hesitant to make a big deal about that, given the small sample of patients and the fact that it was not a primary endpoint.
Exactly.
We were not powered for it.
Exactly.
So it is interesting, but if anything, hypothesis generating.
So what does the future look like for 0 head position stroke management?
My big takeaway from all of this, and this is particularly true in any patient that cannot get immediately to thrombectomy, is that we need to put the head of the bed down at 0 degrees. I would be very hesitant to do another trial where I disadvantaged a patient by sitting them up. I would really struggle with the ethics of that. And clearly it was safe to put patients down at 0 degrees, and it certainly may be, advantageous for the patient to have that done. But I think my biggest concern is for those that require some type of transport for a thrombectomy from, say, a primary stroke center or acute stroke ready hospital by either air or ground ambulance, because when you consider those patients, it's very likely that the moment that they get them on board, they're going to sit them up. And that's done for a number of reasons. The space within, for example, a small helicopter is quite limited, and it's easier to actually put the monitor behind the back frame. And so sitting the patient up allocates that room. And pretty much the very same thing happens in an ambulance as well. I know that those patients would be very seriously at risk, I think, because typically this is a 90-degree angle that they're sitting these patients up at to accommodate the monitor. So I really would like us to do some kind of implementation work, perhaps with the EMS community and the air transport community, to see if we can really have some discussion with them about changing their standards of care for a large vessel occlusion transport.
I've already heard discussions on the floor in the pre-hospital environment, though your study was not designed in that setting. You can certainly imagine from first point of medical contact through decision for thrombectomy or advanced imaging, we're often talking hours, and that crucial few hours make a big difference for outcomes. So I agree. I think you will get a lot of interest from the pre-hospital community in head position. It's simple, it's pragmatic, and it's cheap.
I agree.
Which really kind of meets the criteria for most pre-hospital research, really,
That's
with
right.
limited budgets. So I think the future is really bright in that environment.
Absolutely. And, you know, even at our big comprehensive stroke centers, there's reasons why patients don't get in immediately for the thrombectomy.
Right.
And so certainly we should be considering that too when a patient arrives there. As soon as we've confirmed a large vessel stroke, head of the bed down at 0.
Well, thank you very much, and congratulations again on the
Thank
Zodiac
you.
trial. Wonderful science, and it's our pleasure to talk about it today. Thank you.
Thank you so much.